Good morning, everyone. I'm Elizabeth, and I did my presentation on what a rotator cuff tear is. Today, we will be defining what a rotator cuff is. We will state what the pathomechanics are, cover like the different clinical manifestations, cover the different tests and measures for it, as well as compare it to frozen shoulder, and also discuss like the different rehab phases, as well as discuss the outcomes, and then give an overview. So what is a rotator cuff tear? Basically what it is that it affects the rotator cuff muscles, and so that's going to be the infraspinatus, supraspinatus, teres minor, and subscapularis. And basically what it does is that it's going to pull away from the humerus, and the same with an injury could be due to overuse. And you have two types, a partial and complete tear. A partial tear is when it's still somewhat intact to the humerus, and then a complete is when it completely separates from the head of the humerus. So there are different pathomechanics that cause it. From when I used Dutton's part in the book, it said that compression is one. There's two types. Primary, which is due to reducing the subacromial space. An example would be like a type 3 hook on the acromion process. Secondary is due to a decreased joint stability on the GH joint, so that could be like when the humeral head compresses on the rotator cuff. Next is tensile loads, or tensile overload, which is also primary, and secondary, which primary is when it resists the rotator cuff movements, which would be like horizontal adduction, internal rotation, interior translation, and other distraction forces. Secondary is due to like a lot of distractive and tensile forces, which causes failure of the rotator cuff tendons. You can also have macro trauma and micro trauma. Macro trauma is due to a lot of different forces from trauma, which will usually exceed the tensile load on the tendon. Usually you'll see it within a lot of like the older population, and it usually leads to a complete tear of the muscle. Micro trauma is usually due to more to a deterioration of the tendons over time, and that leads to degenerative tears to not having enough healing. There are different signs and symptoms. Usually some of the main ones will be pain within the shoulder that usually will radiate to the outside part of the arm and will go down to the elbow. You can have issues with sleeping at night, wake up due to the pain. There's also shoulder weakness that can cause you to have issues with lifting items, as well as just like lowering, raising, or even like rotating your arm. You could also have sensations of popping, clicking, cracking within the arm, and you move the arm around into different positions. Some functional limitations that I found within the studies that they did it on just like some simple ADLs, so like washing your armpits, reaching forward, functional pull, of course, with the external rotation of combing the hair, the perineal care, upward reach to 90 and upward reach to 105. And what was found is that they did that the orthodox used the internal rotation more as opposed to external rotation. That led to more damage down the line within their rotators. So some different tests and measures. It can be diagnosed with an X-ray, which is like for arthritis or bone spurs. MRI and ultrasound are used for tendon tears within the rotator cuff. So I did do, there's a lot of different tests that I did, so I'm going to try to make this quick. So the first test that I did was the MTCAN test, which tests for the supraspinatus, which is one of the rotator cuff muscles. Several of these bullet points are just talking about like the position of the patient would be in, and like where the therapist would apply resistance. So it's considered positive if the patient has weakness or pain within their rotator cuff, within the supraspinatus muscle. Next, I did the internal lag sign, which tests our subscapularis tear, and that's just listing a bunch of the different positions of like how the patient would be in the clinician. So basically, if the patient can't, and they release their wrist, and if they can't release it and keep it off their back, it is considered a positive test. Then the external lag is testing for the infraspinatus, and what that does is that the wrist will also be released here, but it's going to be positive if you have a lag as well as the arm is not kept within your full internal rotation. Is the infraspinatus test, which this does test the infraspinatus muscle. Similar to the external lag sign, you can have pain or weakness, and especially you'll also see this if there is an external lag sign. It can also show impingement at the subacromial area of the shoulder. Drop arm is another one, so basically the patient will be standing with their arm out to the side, and the therapist will release it and tell them to slowly drop their arm. If they can't do that, or if they have issues when performing the task, that is also indicative of a rotator cuff pathology. So next we have the painful arc, which similar to the drop arm, you go through the range of motion, basically from abducting, and that will show impingement within the arm anywhere from like 160 to 120 degrees if positive for that. And then horn blowers was another one that I found. This one's more for the teres minor, and it's positive if the patient cannot externally rotate their arm. And the one functional test that I found was the Apley's scratch test. So there's like different positions that the patient will do. The first one is doing the arm over to the opposite shoulder, which that will be positive if there's like uneven results, and they will have limitations within abduction, internal rotation, horizontal flexion, even some scapular protraction. You also have the second one where they go behind their back like this. It's positive if they also have uneven results and decreased motion, which will be limited within abduction and external rotation, and they could also have issues with upward rotation and elevation as well. And then the last position is the third one where they go behind their back and bring the arm up behind their back, and usually what that shows would be issues with limited femoral abduction and internal rotation, as well as limited scapular retraction and downward rotation. And then of course the different ranges of motion, I went with shoulder flexion, shoulder extension, shoulder abduction, and shoulder internal and external rotation, and the normal ranges are listed here on the PowerPoint according to Morgan and White. Also listed the same areas for passive motion too that would be used to assess for a rotator cuff tear. Manual muscle testing and muscle selective tension testing. I listed shoulder flexion, shoulder extension, abduction, shoulder external rotation and internal rotation, along with some of the different muscles that would be used to assess the rotator cuff and determine like which muscles that it could be. So for the differential diagnosis, I compared it to frozen shoulder, or also known as frozen shoulder contraction syndrome. And so both do cause pain and immobilization within the arm, but frozen shoulder is also gonna cause restricted movement. But the thing that sets it apart is that you have 3 stages. So within the first stage, you're gonna have these different systems here, constant pain, you will wake up at night, as well as disturbed sleep, just like with rotator cuff, but you also will have issues with limited motion. You don't wanna get any, injections, and this is between the first 3 to 9 months. Next stage is frozen, which you usually just have pain within moving your arm. There can be adhesions as well within this area, and there will be a lot of limited motion, especially within abduction and external rotation. The muscles do tend to atrophy a lot here, and this is going to be anywhere between 9 to 15 months after onset. And then the final stage is thawing, which basically pain starts to decrease here. There can still be some restrictions of motion due to adhesion within the capsule. You don't have any synovitis, which is inflammation of the synovial membrane. And from what I read in Dutton, the infill tends to be capsular due to tissue resistance. Motion does tend to improve, but some people don't get their full range of motion back, and this is anywhere from about over a year to 2 years after they've had the condition. For the rehab process, usually after you've had surgery, you want to get a sling, and that varies on the tear. So it's listed like depending on the size of the tear, the amount of weeks that they will need to have the sling on. So first, overall, you just want to make sure that you're just protecting the tear, as well as first want to minimize pain and inflammation. You can do this by ice, tins, making sure you support the arm, taking medicine, as well as doing like different oscillations, making sure to prevent movement within, losing movement within other areas where you want to practice like the AAA ROM on different areas, as well as making sure to prevent stiffness. You can do like a pendulum exercise, which is what I have a picture of there, and also making sure to keep range of motion within safe areas to not cause pain, and to make sure that you don't, and you do self-assisted ROM, and it varies on the size of the tear. Then you also want to continue to do active and assisted motion. One thing I read in the book for therapists was like you can flex the arm eventually up to 90, start doing like small arcs and circles. Another thing, once you progress from there, is that when you have the elbow flexed, eventually once they can do that, you can want to start progressing to semicircling of the arm. From there, you still want to make sure that you're not causing any issues with posture to degress, so make sure to do exercises for that, as well as to also control the scapulothoracic stabilizers, so doing like active range of motion, isometrics, and even doing some exercises where they're lying on their side and concentrating on protraction and retraction. And then for the last part within the first stage, you want to make sure that you have inhibition and stop the atrophy of the glenohumeral muscle. So one way you can do that is doing low intensity setting exercises with minimal resistance. An example that I included was a front shoulder raise, and eventually once when they've gotten through this phase, you want to make sure that the incision is healed, as well as to reduce the overall pain within the shoulder and to improve range of motion. Phase 2, you want to make sure that you are developing control of the nerves and muscles and getting strength and endurance back up so that you can get range of motion back, and of course course, the phase depends upon how small or big that the tear is. So here you want to focus on getting mobility back within the shoulder. Of course, with it being pain-free, you can do self-assisted ROM, doing like cooling exercises as the picture is showing here. You also want to start mobilization on the joint just to kind of like break up the scar tissue and making sure that the incision is healed. Also want to increase the strength and endurance for mobility, especially with getting active range of motion back within the shoulder. So you want to increase that, and some ways you can do it is doing elevation of the arm, but you want to eventually also progress to sitting to standing exercises, where I did an example of standing band shoulder external and internal rotation. And then from there you want to progress to doing some isometrics and strengthening. Make sure to change from in between them. Also do some rhythmic stabilization where you're having like lightweight bearing activities within the upper limbs. So an example would be like a standing row. You can also do submax isometrics where you're focusing on strengthening the rotator cuff and the glenohumeral muscles to, of course, gradually increase the resistance for that over time. And for the last part here, you want to make sure you're still continuing to strengthen the endurance training. Still keep it lightweight. If they have pain, keep it below shoulder level, and of course be mindful of the amount of load that you are putting on the shoulder. So an example of this type of exercise would be in a resisted band shoulder upright rows with bilateral backs. I couldn't find a picture of that, so I included a picture of an ergometer instead, since that's another exercise that you can do, as well as with any like other upper extremity light activities. And to progress from this phase here, just making sure that there's no pain within the range of motion, to improve the strength and endurance, and making sure that the GH joint is stabilized and secure. Then once you get to the final phase, this is going to be around 12 to 6 weeks. It could even take up to about 6 months, just depending on the patient. So depending on how big the tear was, you want to keep doing the same protocols as from after surgery, and keep precautions as needed. If they've not gotten full range of motion back, you want to do continued passive stretching, do joint mobilization, continue to do active activities to increase ROM, and depend on the patient, make it task specific. So an example would be an inverted kettlebell hold to press, and if they can tolerate it, to do that exercise, you could do it standing or kneeling. And then the last part of this phase is that you still, upon protocols, you don't want to do too many high demands, because it usually takes about 6 months to 1 year still after to not want to cause the tear to re-tear again. This usually depends upon the strength, comfort, and flexibility. And overall, patients that have a rotator cuff tear do tend to see treatments both non-surgically and surgically, but it does take time. It is possible that they can have a re-tear, again, especially if it was really big, like bigger than 1 inch, and then also the re-tear could also lead to pain and movement loss, which may require another surgery. So overall, we looked at what a rotator cuff is and how it affects the muscles and the various signs and symptoms, and it can limit functions like with being able to reach overhead with different ADLs, as well as various testing measures, because there are a lot out there. There are even other ones that I found that I didn't include in here. I did also compare it to frozen shoulder, and again, rehab for it is long, but people do usually tend to see improvements. And these are my references.
Alright, so she mentioned painful arc in there. range that she said you might see a painful arc with rotator cuff tear. Okay, so 60 to 120, right? So what if a person said that they were fine here, but they get up here, right here in the closer to end range, and they had that higher, what did I hear? AC, okay? So there's different things that we're seeing. We're seeing they pick up these trends, right? This is really important for you to recognize these subtle differences. It's going to help you in figuring out how to best help your patient. So you also brought up when you were doing your differential diagnosis, so with adhesive capsulitis. So one comment with the you brought up with an adhesive capsulitis that you may see a capsular infield, right? So let's dive into that just a little bit more, because I just want to try to help you guys make these connections. So Jackson got with the empty infield, awesome. All right, so you brought up the capsular infield. So with the capsular infield, how would you qualify that with the entry level classifications of soft, firm, hard? What would you say the capsular would fit? Firm, so you might say it's a firm infield due to some capsular restriction, feels capsular, okay? But then for the purpose of practical too, and just for knowledge sake, if somebody came in with an adhesive capsulitis and they had a firm capsular infield, do you think that's gonna be more of a normal or an abnormal capsular infield? Firm infield. Okay. Probably an abnormal versus somebody who came in and they felt they had full range, but they're at the end range, it felt firm and it felt like more like capsular restriction. How would you classify that? So I would say this is a normal firm infield due to, it feels capsular, due to capsular restriction. So kind of get in the habit as you're looking at patients and as you're feeling these to start making those differentiations in your mind. This feels like a firm infield. I think it's a normal infield, but it feels like it's more, muscular tightness versus a capsular versus this is a normal soft infield because of soft tissue approximation or you know what, at this joint, I'm feeling a soft tissue approximation at soft infield, but that's not really what I think I should feel here. It's not what Norkin and White tell me I should feel right here, right? So start making those differentiations and start thinking about it. So, good job.